But I'm Katherine Hoops. Thank you all for having me. I will give a little bit of an introduction to myself in a subsequent slide, so I will just go ahead and get started. First, the requisite disclosure slide, of which I have none. There we go. Although I do receive funding support from NIH and CDC, a little bit of that research I'll talk about over the course of the hour. But I also wanted to hold some space for a trigger warning, right? Acknowledging that all of us come to this discussion with our own life experiences, and that contributes to how we perceive information. And so some of these topics that we've discussed today may be triggering for folks in the room or on the Zoom. Those topics include racism, interpersonal violence, and suicide. So please know that I'm talking about these subjects for the purpose of intellectually engaging on the subject matter. My intent is to support everyone in a supportive learning environment. But because many of us have experienced trauma related to this area of work, some of this material may be triggering. So please take whatever steps you need to ensure your emotional safety, including if you need to taking a step away from the session at any time. But thank you again for engaging in this conversation with me. Okay, so for those of y'all that I got to speak with last night, you've heard a little bit of my on-ramp and kind of how I came to this work. But for the folks that are new to me that I'm just meeting, I like to give a little bit of a background story to how I came to this area of research. And that's kind of my training pathway there with the little the Google Map dots. But I am from Alabama. Technically, I'm from Niceville, Florida, which is a pretty little coastal town across the bay from Destin, which some folks may be familiar with. It's a popular spring break destination for folks in these parts. But Eufaula, Alabama is where my family hails from. It's where I've always called home. And this little slice of heaven in the middle is where I spent a lot of my free time growing up as a kid. And this is the commercial hunting camp that my family owns and operates still. I was taught about guns and gun safety from a young age. And I'm a longtime gun owner and avid hunter myself. I grew up in an entrenched gun culture, right? Surrounded by hunting and shooting sports, a daughter of the Army, later a civilian contractor for the Air Force, so surrounded by U.S. military and family. But as I was going through my medical training, I went to med school at the University of Miami. I realized that most of my colleagues were not nearly as comfortable talking about gun safety as I was. But then when I went to residency in Birmingham, Alabama, where I did my pediatrics residency, I got to see from many of my co-residents who are also hunters and gun owners that our patients were actually really receptive to this counseling when you knew what you were talking about. So I saw my role in this space as really trying to help bridge that gap, right? Helping to train clinicians to have more nuanced, patient-centered conversations about guns and safety, especially as I saw my patients dying from firearm injuries. But also along the way then I end up in Baltimore for my pediatric critical care fellowship, and I've since stayed on as faculty. Now I get to work in the Center for Gun Violence Solutions, leading the clinical programs and practice team there, translating public health evidence into clinical practice. But you don't have to do this work for very long to realize that 100% perfect adherence to safe storage all the time isn't going to fix the fact that young Black men are systematically denied opportunities to, education, economic opportunities, maybe pulled into illegal economies, exposed to violence, exposed to chronic trauma. And, so I then, in search of more tools for my personal toolkit and my institution's toolkit for how to, more comprehensively, holistically address violence and injury prevention, I decided to go to law school. So I became interested in medical legal partnerships and how, those social determinants issues that have legal remedies, how we can better address those more effectively in the clinical setting through medical legal partnerships. So I just finished my JD and I'm now working on medical legal partnership program building that's adjacent to our hospital violence intervention program. So this is not to say that every MD needs a JD to advance violence prevention initiatives at all, right? It is really just to say that, and I love this graphic from my colleagues at Cities United, because I think really, hopefully that reproduces okay. It helps to show that violence is a symptom, it's not the disease, but it requires an all hands on deck approach. And, all of these tools, right? Medicine, law enforcement, faith communities, right? These are all offer tools that belong in a toolbox with other tools. And my intent today is to talk to y'all about several tools for violence prevention that I think are most relevant to us in our clinical practice. So my objectives are these. We're going to describe the epidemiology of firearm injury and mortality in the US, and then focus in on Nebraska. We're going to describe some conceptual frameworks that guide this work. Along the way, we'll recognize some common risk and protective factors for firearm injury and violence. And then I hope to devote more of our time at the end to identifying clinical strategies for violence injury prevention, especially kind of universal safe storage, but also kind of that risk-based lethal means safety, and of course, hospital violence intervention programs. And I'll end with a little bit of a policy landscape as well.
Dr. Hoops, if at all possible, I think the volume's all the way up, but a few folks are having a little bit difficult time hearing you. I essentially project.
Where is the microphone?
I think it's that one right
It's
there.
in the ceiling,
Yeah.
and if I join the audio, I'm afraid that will echo, but I will just try to talk really loud.
The volume is all the way up.
Okay, well, so raise a hand if I start to drift, if I'm
Okay.
too soft. Thank you, no, sorry. I don't often get accused of being too quiet, so, so I'll just try and project more. So first and foremost, what is the scope of the problem nationally? It's enormous, right? So in 2022, 48,204 lives were lost to gun violence nationwide. Over 27,000 of which were suicide. We're going to look at this data in a slightly different way on the next slide. But I wanted to, on this slide, highlight for y'all, this QR code will link you to the full 2022 report that my center issues each year when the CDC firearm fatality data finalizes. And each time with a focus area. So for 2022, the focus was youth violence prevention, or was youth violence or youth injury. And so a lot of the graphics that you'll see over the course of the talk focus on youth particularly, which is fine by me and how I usually structure my talks as a pediatrician. But the forthcoming 2023 report, which you'll also find on the center's website here in a couple weeks when it finalizes, will focus on suicide, which I think will be a topic of interest as we get further into this data. So, as promised, the data in a slightly different way. So, contrary to what we see in the media, usually highlighting mass shootings and homicide, suicide is actually the leading cause of firearm death in the US. And about 54% of gun deaths in 2022 were suicides. And I'll flag that this number varies year to year, but each year about a third of firearm suicides are among a military population. So active duty service members, veterans. So I don't mention a lot of, veterans mental health specifically, but I did just want to flag here that this is a really important population to think about when we're thinking about firearm suicide. But the greatest increase that we've actually seen in recent years in terms of firearm suicide has actually been among American Indian and Alaskan Natives, among whom we've seen a 42% increase in firearm suicide over the last several years. Homicides represent in 2022, 42% of gun deaths. Now, if I were talking to y'all in 2018 or any of the preceding 25 years, I would have said that number was 35%. But because homicides increased by 35% between 2019 and 2020, homicides now occupy a larger portion of that pie, if you were looking at a pie chart here, the graph, such that now they contribute more to kind of the overall burden of firearm deaths in the US. So in 2022, 48,204 people died due to gun violence in the US. That's the second highest number ever recorded. Each day, that's 132 people dying by gun violence. That's 1 every 11 minutes. The overall gun death rate in 2022, though, did decline by 2.3% from the preceding year. And gun homicides actually decreased by 7.5% in 2022 as compared to 2021. Well, before I say but, that's also 1,300 lives saved, right? That 7.5% was 1,300 lives saved from homicide as compared to 2021. But despite those increases, right, we see almost 20,000 people dying by gun homicide each year in the US, and such that 2022 was the second highest number of gun homicides ever recorded in the US. Meanwhile, gun suicides continue to increase and reach all-time highs. So from 2021 to 2022, we saw a 2.7% increase in firearm suicides, resulting in the highest number ever recorded of gun suicides. Those smaller sections at the bottom of the slide there represent about 4 to 5% of gun deaths each year, or about 1,500 deaths that are unintentional injuries, undetermined intent, and legal intervention or officer-involved shootings. But I'll flag that we don't have a national system for capturing officer-involved shootings as a kind of context for firearm deaths. And actually the best available data comes from the Washington Post, which tracks these events and the events that surround them, and to the best that they can. And each year we know that that's about 1,200 deaths. You'll notice here that mass shootings isn't a distinct subgroup, but mass shootings as defined by the Gun Violence Archive as 4 or more victims, not including the shooter, account for about 2% of gun deaths, and those are included among homicides on this graph. As a pediatrician and a mom, I do just want to distinguish some important differences between youth firearm deaths and kind of the overall trends that we see. So, and these are 2021 numbers, but the proportions are largely unchanged, right? But here you're going to see that the majority of gun deaths among people under age less than or equal to 24, under age 25, are mostly driven by homicide rather than suicides. But there are some really important trends in youth suicide by firearms that I'll highlight later in the talk. So in the next few slides, I want to show a few individual level factors that can mitigate risk or elevate risk of firearm injury. And in this case, I want to show the burden of firearm injuries, especially among young people in the US, right? With the highest numbers of gun deaths happening between 15 and 35. And I highlight this in this context too, because when we say that we're implementing data-driven programs, even this very basic data informs how we develop some of our interventions, right? So when you look at the model for hospital violence intervention programs, these are designed to target that highest risk cohort, usually in that 18 to 35 age group, recognizing that this is a population among whom we see some of the highest numbers of gun injury. But you see that number continues such that actually the largest total number of gun deaths are among older adults, as we see that risk of suicide continue throughout the life course. And while these numbers at the bottom are relatively low bars on this bar chart, I want to highlight that firearms are the leading cause of death in kids ages 1 to 17 in the US, right? So in 2022, 2,526 children and teens died by a firearm. And that's an average of 7 young people every single day. And if we looked at all of the deaths that happened for kids ages 15 to 17, we would see that 30% of those were due to a firearm. Here, sex, and I want to highlight that Whiskers currently is the database for CDC that captures a lot of our injury and fatality data. Currently only includes sex assigned at birth. There isn't a mechanism for capturing gender identity in these reporting systems in their current iterations, but suffice to say, even from this data, we see the substantial difference in risk between males and females, right? 87% of firearm suicide victims are male, and 84% of firearm homicide victims are male. But if we looked within the women's section of that block, you would see that 50% of gun deaths, especially gun homicides among women, are due to intimate partner violence, or the homicide was perpetrated by a current or former intimate partner. So I just think that that's also a really important population for whom we need to be thinking more comprehensively about resources and services. And finally, race. We all know, we see in our practices that Black Americans, especially young Black men, are disproportionately impacted by gun violence. We see, this is I don't know how well the text reproduces for folks, but just a substantially increased risk for firearm death among Black Americans. But also, when you're thinking about percentage population, the also substantially increased risk seen by American Indian and Alaskan Natives, noting again those important increases in suicide in recent years. So this is the gun homicide rates for youth by race. In 2022, Black youth in this age demographic, age 1 to 17, had a gun death rate that was approximately, overall gun death rate, that was approximately 6 times higher than their white counterparts. These disparities are especially stark when we're talking about gun homicides, right? So for children and teens ages 1 to 17 in 2022, the gun homicide rate for Black teens ages 1 to 17 was 18 times higher than that of their white counterparts. And the gun homicide rate for Hispanic and Latino youth and teens was 3 times higher than their white counterparts. So we could spend the entire hour really just talking about these individual level factors and really important health disparities. But we know that these individual level factors play a difference and then come through into how we are designing and implementing clinical programs to reduce violence. So this always feels like a really fast tour of really important data. So forgive me for the broad strokes and brief treatment of these really important issues. But I do want to save time for us to talk more about local data and also more about solutions where we can work together. So again, all of those individual level factors really play an important role. And location matters too. I'm going to say means matter a lot. Location matters too, but maybe not in the way that you would think, right? Gun injury is an everywhere problem. I think, that sometimes people are surprised to see that there is a less stark difference between urban and rural communities in terms of homicide rates, but perhaps even more so, people are surprised to see that there is such a substantially higher rate of firearm suicide in rural as compared to urban communities, that there is actually an overall higher rate of gun deaths in rural communities. So some of this we know likely tracks to reduced availability of mental health services in rural communities, but it certainly also contributed to by the prevalence of firearm ownership in rural communities. And I just said location matters, individual level factors matter, location matters, means really matter. So I want to focus on suicide for a second here, because I think this is really illustrative. You see here, this is the distribution of mechanisms for overall suicide attempts, fatal and non-fatal. And that little green wedge you see there is firearm attempts for overall suicide attempts. you see that the vast majority of them are by overdose or toxic ingestion. But because of the case fatality rate of firearms when used in the context of suicide, firearms are extraordinarily lethal, right? They have a case fatality rate of 85 to 90%. So that means, right, if you attempt suicide by firearm, there's an 85 to 90% chance that you are going to die from that attempt. Contrast that to overdose or ingestion, which has about a 3% case fatality rate. Then we see, because of that high case fatality rate, that little 6% wedge in the attempts then becomes 54% of fatal suicide attempts. So 54% of suicide deaths are due to firearms. And, I probably don't need to show this graphic, right? Because many of us have seen this in our practice as well, but this shows the percentage of Black high school students reporting seriously considering suicide in the previous year. And so I just want to point out the incredible increases in suicidality among Black youth, especially Black girls and Black LGBTQIA youth in recent years. That I think really inform how we should be approaching mental and behavioral health services to some of our patients. So means also matter when we're talking about homicide, right? When we look at homicide in the US, for non-firearm homicide, we're actually about the same as our economic peer nations, but firearm homicide separates us. Right, there is 25 times higher than most of our economic peer nations. And that gives us an overall homicide rate that's about 3 times higher than most of our economic peer nations. So this availability and the lethality of firearms really contributes to our nation's high suicide and homicide rates overall. So just again, to highlight some of that, some of those data points from before. Right, 48,204 lives were lost to firearms in 2022. That's the second highest number ever recorded, and that's 1 person every 11 minutes nationwide. 27,032 of which were firearm suicide. 2,526 of which were youth, children and teens. Black teens and youth were 18 times more likely to die by gun homicide than their white counterparts. And the rates of gun deaths by Hispanic and Latino youth have doubled in the last year. Now I want to take the opportunity to focus in a little bit more locally. And I highlighted our national data report that we do each year when the CDC data finalizes. But as a companion to this, we also always publish state level analyses, and kind of you'll see some of the graphics that we produce as related to this, but I, especially after some of our discussion last night, I look forward to seeing this data for Nebraska finalized for 2023 as well. But just a kind of a high level overview of some statistics. And I want to just point out, right, that this is the national average here of gun death rate overall per 100,000 by state. And you see Nebraska almost next to my current home state of Maryland here, but below the national average. But you see, or kind of, not really, this doesn't reproduce super well because it's tiny, but you see that especially when you're looking at youth, you see that this is largely driven by a high gun suicide rate and a high rate of unintentional injuries among youth. So adding some numbers to that, right? 1 person was killed by gun violence in Nebraska every 36 hours in 2022. That was a total of 244 gun deaths statewide. Of those, 48 were homicides and 185 of which were suicides. 11 were coded as other or undetermined intent, and 10 of them were children and teens ages 1 to 17. So overall gun deaths, primarily driven by an increase in suicides, rose in 2022. The gun death rate actually increased by 18% in Nebraska from 2021 to 2022. And from 2013 to 2022, the overall gun death rate increased by 35%. The gun suicide rate alone increased by 55% in that same time frame from 2013 to 2022. And that's the second highest gun suicide rate increase in the country, statewide during that period. So when we look at gun homicide in Nebraska, we see that males were 3 times as likely to die by gun homicide as females from 2018 to 2022. And while Black people make up 5% of the state's population, they account for 45% of gun homicide deaths. Focusing in on firearm suicide, we saw that males were 8 times more likely to die by gun suicide than females. And then this kind of breaks out a couple of different age cohorts and some important statistics. So white males over the age of 34 account for 22% of the population, but 56% of all gun suicide deaths in 2022. If we look at people under age 35, they accounted for 34% of all gun suicide deaths. And the rate of gun suicides in this age group in the last several years, since 2018, has actually increased by 75%. That's the gun suicides in people under age 35 in the state. And kind of the group that we typically think of as being some of the highest risk for firearm suicide, folks over the age of 54, we actually saw that those were 37% of all gun suicides statewide. So firearms are used in the majority of homicides and suicides in Nebraska, mirroring the national trends. That's the darker bar right there, percentage of suicides using a gun, mostly firearms, percentage of homicides using a gun, mostly, or percentage of homicides, mostly firearms rather than other mechanisms. And if that data wasn't sufficiently compelling, gun violence costs Nebraskans $3 billion every year. But I want to highlight, especially in light of some of the conversation that we had last night with some of y'all's amazing community partners, that there have been some really important innovations in this space and interventions that are making an impact in this community. So since 2022, in U-Turn, one of y'all's community partners, a community violence intervention program, I'm sharing this data and lifting it up courtesy of their executive director, Ms. Negrone. They have lost 0 clients to gun violence. They have prevented 35 firearm assaults and incidents. And they have seen a 70% reduction in non-fatal shootings in their service area in the last 2 years, between 2022 and 2024. And again, if that wasn't enough, they've also saved between $35 and $100 million through their violence intervention programs, which have reached through their outreach events over 1,000 people. And I got to meet their team yesterday, which was really humbling and incredible, and can definitely testify to this. It's probably a lot higher than that. But they have spent over 3,000 hours of person time pouring out into their communities, engaging their participants. So this is part of the reason why I say I'm looking forward to reviewing statewide data and seeing how some of the things that y'all are doing in the community are already having a really important impact on this data. So now I want to turn to how do we fix it? And I want to share a couple of conceptual models that can shape how we think about the problem and its solutions. And chief among those is the public health approach to violence prevention, right? Like we talk a lot about applying a public health lens and the public health approach to violence prevention, but what really is that? What do we mean when we're talking about the public health approach? And it's pretty simple, right? We're talking about understanding the scope of the problem, understanding, the root causes of violence and, the protective factors against violence. We're learning what works and for whom, and then we're scaling up the effective stuff and then continuing to reiterate this, right? So I think, U-Turn is applying a public health approach, intervening with an at-risk group with targeted services and scaling up those targeted services and continuing to reiterate this cycle. But anyways, this is the public health approach. The social ecological model is another conceptual framework for violence prevention. It's the one that CDC uses. And it's another way of exploring those risk and protective factors and thinking about developing interventions, right? And I like this depiction of the model, right? It includes individual, relational, community, and societal factors, and helps to understand the range of factors that put people at greater risk of violence and protect them from it. And you see how these domains overlap, right? This illustrates how relational and community factors influence individual level factors. But I also think it helps to highlight that we need to be intervening at multiple levels to create durable, sustainable, most efficacious interventions that can reach entire populations. So what do we mean when we're talking about individual level factors, right? That might include age, education, income, also a history of abuse. Those prevention strategies, at the individual level might include those that promote, attitudes, beliefs, individual behaviors, actions that can help to prevent violence. And some of those interventions might include conflict resolution training, might include social emotional learning and digital literacy curricula like we talked about last night. They might also include safe dating educational programs in schools and elsewhere. The relational level considers the influences of one's closest social circle peers, your family, your partners, your closest friends. And those interventions might include parenting programs, mentoring, and peer support programs, those that promote positive social norms. At the community level, these explore the environments in which those relationships occur, right? So schools, workplaces, faith communities, neighborhoods. And these prevention strategies, at this level, focus on improving the safety and strength of physical and social environments, such as those that promote neighborhood safety and engagement through things like poverty, addressing poverty, blight remediation, housing instability, residential segregation. The fourth level is including on societal factors that can contribute to violence, emphasizing policies that can reduce structural determinants of health and inequity. And finally, my personal favorite conceptual framework, the Haddon Matrix. This is essentially the starting point for thinking about any injury-related problem, right? And you work through these pre, intra, post-event factors in the epidemiology triangle of host, agent, and environment. And these were designed by William Haddon, who's a physician and injury researcher, and one of the first directors of NHTSA, the National Highway Traffic Safety Administration. And he was a pioneer in automobile safety and probably the original champion of airbags. But if we were to develop and apply a Haddon matrix to unintentional firearm injury, for example, right, we'd be talking about safety training and safe handling behavior training for that human pre-event box. We'd be talking about biometric locks or safe gun technology for those things that prevent unauthorized users from firing a weapon in the pre and event vector boxes. And we'd be talking about normative social behavior around safe storage in the pre-social box. So I offer these just as kind of a jumping off point to start thinking about how we're designing these interventions and the conceptual models that guide us. Because after spending a lot of our time on some really sobering statistics, I want to end on a more empowering note, right? That we in the House of Medicine are not powerless against the constant toll of gun violence in our communities, right? There is much that we can do in our setting to help to reduce violence and injury and diminish the impact of the chronic trauma that it causes. And I want to talk to you about a few of those things. So first and foremost, I think we can create trauma-informed systems. And I love this illustration of kind of what a trauma-informed system looks like. But in its simplest form, trauma-informed care means recognizing that trauma is ubiquitous, right, among our patients, but also among each other, among our colleagues, right? And being trauma-informed means recognizing that when someone doesn't respond like you thought they would, instead of asking, well, what's wrong with them, right? You instead are creating a safe space to process what may have happened to them in the past. And I really think that we all have a role in creating safe and compassionate environments in which we provide care. And it all starts with educating ourselves on trauma and stress. And I wish I could spend more time on this topic, but suffice to say, I think, you know, trauma-informed care is really important to how we're approaching all of these interventions, perhaps most especially the development of hospital-based violence intervention programs. So I'll highlight kind of some of the national model for what a hospital-based violence intervention program is, and I'll kind of zoom in largely because I like sharing pictures of my team, show y'all a little bit of our team in Baltimore. But several years ago, we undertook a study to look at trauma re-injury, assault re-injury in Baltimore. And, you know, we saw that our trends were pretty much the same as everywhere else. If you did this study nationally, if you did this study in any city, in any state, it looks about the same, right? That when someone comes in with an assault-related injury, there's about a 15 to 25% chance that you will see them again for another assault-related injury. And each time that they represent for care with each subsequent assault-related injury, their risk of death from that injury doubles. And we saw that in Baltimore, and we see that nationwide. But we know, one, then that our space is a really important place to be providing targeted interventions, to be helping to intervene with a trauma-informed holistic approach. But we implemented a hospital violence intervention program to try to help address this. So this is a graphic from the HAVI, the Health Alliance for Violence Intervention, just showing what a hospital-based program is, right? You pair an intervention in the clinical setting to help walk with someone through the course of their care in the health system, and then provide long-term case management, peer support programs, and follow-up services to help address the social determinants of health that may be, prohibiting or restricting someone's ability to reach their broader goals. So these models they employ a kind of a comprehensive case management, social support program to help patients interrupt that cycle of violence. And, because we know, as part of applying the public health approach to violence prevention, that exposure to violence is a risk factor for re-injury. But, during that time of introspection and vulnerability that often accompanies a serious injury that might end up with someone presenting for care after an assault, this is a time and opportunity to intervene with assault injured youth and young adults to help to reduce violence. And we need to utilize these opportunities to develop interventions in the hospital setting to address those modifiable factors. And to do that, our team looks like this. We're a multidisciplinary team of case managers, social workers, and our violence intervention specialists, all of whom have, can harness the power of their lived experience to be credible messengers to patients who are currently, in this life. And so they're a really important, really the heartbeat of the program is our credible messengers, our violence intervention specialists. And then, there's a few of us physicians who really just get to champion and learn from the team alongside them. Another big thing that I think we can do in the hospital setting is lethal means safety and safe storage counseling. And I'll talk a little bit more about what safe storage is, what lethal means safety is, and kind of a hierarchy, a spectrum of interventions. But starting with some level setting, we know that household level gun ownership doesn't cause suicide. It doesn't cause firearm injury, but it does increase risk, right? And we know that 35 to 40% of homes with kids have at least one gun. And we know that firearms are used in over 40% of fatal suicides among those age 13 to 17. And most of those were obtained from a family member or friend. But safe storage can prevent and reduce gun-related injuries and deaths, especially in youth. And especially when compelled by law, we know that safe storage laws also further reduce firearm deaths, especially in youth, but across the spectrum, not just suicide. So youth homicide, youth suicide, youth unintentional injury, and really importantly, and oftentimes I think one of the most compelling things that I can share in a clinical setting is that safe storage prevents theft, right? So we know, and this is a dramatic undercount, but these data are from the most recent ATF report on lost and stolen firearms. We know that about 300,000 to 400,000 firearms are stolen from cars and homes each year. Many of these firearms are later used in crime. So these gun theft is a huge, very important portal of entry for crime guns. So what do we mean when we're talking about safe storage? So first and foremost, it's a spectrum. And at the foundation is universal safe storage, right? The idea that it's a central tenet of responsible gun ownership, that lots of firearm safety groups and the National Shooting Sports Foundation champions a lot of initiatives around the importance of safe and secure storage. But this is the foundation, kind of, it's a central tenet of responsible gun ownership, that all guns, when not in the use or direct control of the authorized owner, should be stored unloaded in a locked case or cabinet separate from ammunition. But this is just the foundation, right? With increasing levels of risk, increasing levels of protection need to be conferred, right? And what do I mean when I say that, right? That if there is someone who is at risk in the home, then additional steps may need to be taken. That's when you kind of start to get into the lethal means safety counseling, kind of more risk-tailored counseling. So that might mean, if the authorized owner of the firearm is going through a hard time and may just need to put a little bit of distance between themselves and access to their firearms, the VA system has actually modeled this really effectively for us, that you can yield control of your safe in a safe and non-judgmental environment to a buddy or a designee, right? I can say to a friend that I'm going through a hard time and I need you to reprogram my safe and for you to just have the code for now. But I still want to have my guns in my house. I still want to be able to access them to go hunting, but I want you to have the keys to my safe, or I want you to have the code to my safe. It might be a friend, it might be a spouse, it might be another family member or a neighbor. But so it might look like safer in-home storage. It might include out-of-home storage, right? There are a lot of efforts to develop statewide, but even a national out-of-home safe storage map. So you can go to these maps and see what gun shops or ranges or law enforcement agencies in your area might be willing on a case-by-case basis to accept firearms for storage in their site, right? Often it looks like just a locker. So you can go, you're going through a hard time, your kid is going through a hard time, you want to get the guns out of your house, you can take them to your gun club or your range and store them in a locker, just to get them out of the house. This can look a lot of different ways, but there's all of these things still preserve that person's right to gun ownership until we're talking about extreme risk protective orders. So extreme risk protective orders are the most restrictive means of lethal means safety. And what is an extreme risk protective order, or ERPO, in the interest of my pyramid there and the increasingly small wedges there? So an extreme risk protective order is a civil legal mechanism by which an authorized petitioner can go to the court and say that for someone who is at imminent risk, at high risk, gravely high risk of violence or suicide, needs to be dispossessed of firearms. So come into the home, you remove all the firearms that are in the home, and then that person is prohibited from purchasing new firearms for a period of time. There is due process, right? There are multiple hearings and opportunities, and not every ERPO that's petitioned for is issued. They're also time limited. If the critical time passes earlier than the statutory period that's allowed, they can be returned to the firearm owner sooner. Sometimes you can petition for a longer time if the critical time hasn't passed in that statutorily described time period. But I say that this is the most restrictive means of lethal means safety, but then, you clearly see that there's something else at the apex of my pyramid, and that's emergency petitions, right? Or involuntary mental health commitments. And, that obviously implicates a whole lot more restriction of one's civil liberties and movements. But I did, just in the interest of presenting the full spectrum of lethal means safety and safe storage, the hierarchy, obviously an EP or emergency petition lies at the apex, but you really think of ERPO as being the most restrictive means of just lethal means safety, if we're just talking about access to firearms. So coming back to safe storage, I want to talk a little bit about, how we as clinicians can approach these conversations, recognizing that I highlighted before, right, that a third of homes with kids, over a third of homes with kids have at least one gun. More than half of those households, doesn't matter if there are kids or not, are still not safely storing all of their firearms all the time, right, which exposes kids to more risk. So, in the ideal world, this is the gold standard over here in my yellow box, right, that all firearms are stored unloaded in a locked safe. But perfect need not be the enemy of good, right? And so in partnership with your patient, decreasing levels of protection are conferred by each of these levels of intervention for safe storage. But all of them are better than keeping a loaded gun in the nightstand, right? So you can store a firearm in a locked box that isn't a safe. You can store a firearm with an internal locking device, like an internal barrel lock. You can store a firearm unloaded with an external locking device, like a trigger lock or a cable lock. I'll say that a cable lock is usually preferred because you can't apply it to a loaded firearm, right? It has to go through the magazine well and the ejection ports. You can't have around chambered in a firearm that has a cable lock on it. But not all firearms can be fitted with a cable lock, or you may not want to fit them with a cable lock. Some of them require a cable lock that's basically a bike lock, right? So in those cases, you might want to think about a trigger lock, but those have some weaknesses, right? You could, again, you want to highlight that these should be applied to unloaded firearms. Or then, right, if really you can't get to any of those things on the hierarchy, even just storing it unloaded and slightly physically separated from ammunition is better, again, than that loaded gun in the nightstand. And, I think a lot of us are, afraid of approaching these conversations in the clinical setting, but our patients want to hear from us on this. I just advanced a couple on my screen. Going back, sorry for the delay. There we go. We were talking about this upstairs a little bit before, that there is a disconnect between, clinicians that say they will often or almost always counsel families to lock up guns. We say 42%. But then when we looked at medical records for psychiatric, pediatric, emergency visits, 625 of them, we saw that only 11 patients were screened for gun access in our system. Of those screened, almost 20% did endorse having gun access. So we know we're missing a huge number of patients who have firearm access and we're not providing counseling. And importantly, there was no relationship between the suicide risk strata and our likelihood of having had discussions about firearm safety. But families want to hear from us on this. This is the work of my colleague, Dr. Paul Nestat, who's a suicide epidemiologist and an adult psychiatrist. And his team did psychologic autopsies or interviews with families of youth ages 15 to 21 who had died by a firearm suicide, a total of 12 families. And they talked to them about, their mental health histories and suicide plan, histories of prior attempts. And I want to highlight one of these statistics. Would an ERPO have been filed if you were aware of the law? In our state, family members, law enforcement, and clinicians can all petition for extreme risk protective orders. And 83% of them said that they would have petitioned for an ERPO if they had known that the law existed. And I'll read you this quote. If someone would just have suggested, you might want to get the guns out of the house, that's what we would have done. We didn't think, So I just want to highlight that, especially in these risk-tailored settings, our patients want to hear from us on this, and we can be credible messengers in this space to help to implement injury prevention counseling. And that's one of the things that we're doing in my research. So I get to lead the Act Fast, or Adopting Comprehensive Training for Firearm Safety in Trauma Centers, two national multi-site clinical trials, both pediatric and adult. And our goals for these projects, I wish our data was ready for prime time, but is to develop a feasible, multidisciplinary, scalable, effective, universal safe storage screening counseling program for trauma centers. And we want to develop a program that improves clinicians' credibility as messengers on firearm safety and just really encourages a more patient-centered, more nuanced approach to safe storage, so that we're taking these steps in partnership with patients and families rather than, I think a lot of the traditional dogma in a clinical setting was, the safest home from firearm injuries is one without firearms. Well, that's just not going to be acceptable to the vast majority of gun owners. It may work sometimes, but we need to be having more patient-centered, more nuanced conversations, or at least being prepared to do so. So, our goals with this toolkit are to increase the adoption, implementation, sustainability of a universal firearm injury prevention initiative within our trauma centers. And to do that, we're doing, chart review to see how well we're doing. It's a kind of an implementation science framework, how well we're doing adhering to basic metrics within the study. We're enrolling patients and families prospectively to tell us, about their experience in our care, receiving or not receiving firearm safety counseling, how that was perceived, how well they've done implementing safe storage once they've gone home and we've provided them with safe storage devices. And we're also talking to a lot of clinicians through surveys, through focus groups, to understand how our toolkit and the educational programming that we're providing is affecting our trauma center clinicians' firearm safety knowledge and confidence delivering a firearm safety intervention. And these are some of the tools that we're producing. So this is a little behind the scenes footage from a module that just to show that it's a huge team and this wonderful resource that we have. This was a module that we produced actually with the ATF, with an expert firearms instructor, to create basically a virtual surrogate for range time, right? A training program that we know can be really empowering for clinicians to have more familiarity with firearms and how to use them and how to use safe storage devices. But we recognize that that's really infeasible for a lot of clinicians to go to a range and do a half day or full day training. So we wanted to create a virtual surrogate for that, which is one thing that we've produced. And then we provide these models. I picked this screen grab. You think I would have picked a better picture of myself, but right, we provide training materials on how to counsel, like what's an evidence-based, evidence-informed framework that you can use to kind of give yourself that prompt as you're counseling about something that previously has been unfamiliar, maybe you're uncomfortable doing. So we provide training and technical assistance on how to implement counseling. And one other thing that 2 slides from now, I'll send you a QR code for, but this is our safe storage handout that we're providing in the after visit summary to all of our trauma patients. Whether or not you have access to a firearm, you're getting some safe storage information. And y'all are welcome to download that, use that in your practice if you find it useful. There's both Hopkins branded ones and non-branded ones that you're welcome to download and use. But basically it just shares why safe storage matters, some basic statistics on youth firearm injuries, and where you can go for more resources. And in the interest of time, I won't spend more than just a second here, but we're also developing programs that we hope then we can scale nationally as more states come on board with clinician petitions for extreme risk protective orders. But we realized that actually petitioning for an extreme risk protective order is a really high barrier thing for clinicians, right? You have to imagine this is going to court for at least 2 days. That's 2 whole days that you can't be seeing patients, that you have to go and navigate an unfamiliar system. So we've developed a model that we learned from our, child abuse prevention teams, our child protection teams, that, really by creating a member within the team who is also an eligible petitioner to have that expertise and more resources, then the clinical team, when you identify someone who's at imminent risk or you believe may be at imminent risk, you can reach out to that expert team member and consult with them, and then they can either counsel on safe in-home storage if they don't think that an ERPO is needed, or they can actually petition for an extreme risk protective order and personally attend the court hearings and arranging the follow-up that's necessary if they do petition. And I share this work is being led by my colleague, Dr. Paul Nestat. Okay, so I wanted to end with a very brief kind of advocacy call to action. My institution prioritizes, there we go, all right, a little bit of a time delay, prioritizes 5 key policy strategies for firearm injury prevention under the tagline, "These 5 Save Lives." We know that when rigorously implemented, the research shows that these can save thousands of lives. Some of which I can hold out as successes for Nebraska, right? Y'all have, a partial firearm permit to purchase strategy, excuse me. But more comprehensive licensing, we know, is one of the most effective tools in our toolkit for firearm injury prevention. Similarly, y'all are doing a great job supporting community violence interventions, but I'm sure there are always ways that we can scale those programs and dedicate more funding to them. Other opportunities, maybe more locally, include safe and secure storage laws, maybe firearm removal laws, and maybe more regulation around public carry of firearms. But again, I just want to hold out these advocacy priorities for my center. Before, just a very quick summary, right, for anybody who just walked in. Firearms are the leading cause of death in the US. Safe and secure storage means keeping all firearms stored unloaded in a lock, safe, or cabinet without an external locking device separate from ammunition. This prevents unauthorized users, including children and at-risk adults, from accessing firearms and is a really important way for firearm owners to keep their families safe. It's been shown to prevent homicide, suicide, unintentional injuries, and theft. But when that's not enough, you consider firearm removal or other escalated parts of your lethal means safety, up to and including extreme risk protective orders. And as promised, my QR codes, there we go. This will take you to the clinical programs and practice webpage where all those safe storage one-pagers in 8 languages live. Please take them, use them as you see fit. Send us your feedback. We'd love to hear from you. And also our ACFAS online resource center if folks are interested in learning more about the study. That's of course my email address. And those are my reasons for being. That's my son, Jack, and Sarah Claire, 10 and 5. And I've left about 6 seconds for questions. I apologize, but I'm happy to stay over for anyone who has questions. Thank you guys so much for being here.
Dr. Hoops, really quickly, you do have 2 questions. One relative to the availability of Nebraska-specific data. Where does it come from, and how often do we get that data?
The data that I show today are all from our 2022 CDC report. So all of these are data collected through CDC. So kind of the best available data for firearm fatalities. These do not capture non-fatal firearm injuries, but those are all CDC data, and they are published for state-specific analyses by my center each year. The 2023 report is forthcoming here in the next few weeks.
Wonderful, thank you. Tracy Rademacher asks if you could reflect on whether law enforcement is a partner in safe storage education or how they might be a partner to the health system in that regard.
Oh, absolutely. I think really there are many partners in the safe storage space. I think, again, this is a topic that's largely acceptable to gun owners. And, I think I mentioned the National Shooting Sports Foundation and the Project Child Safe initiative. They've actually distributed hundreds of thousands of gun locks through local law enforcement agencies. So local law enforcement agencies, if they are already connected with Project Child Safe, may actually already be distributing gun locks, or that may be a resource, to share with local law enforcement, to be able to share more safe storage. But absolutely, I think law enforcement is a partner in this. I think, when you think about the, kind of the hierarchy of credible messengers on firearm safety, clinicians are not at the top of the list of most credible messengers among firearm owners about, firearm safety, right? Then you should be thinking about law enforcement, military, hunting and shooting sports foundations. So absolutely, law enforcement can be a very important, effective partner in conveying a safe storage message.
So throughout the whole thing, I'm saying, do they hand out these locks and safes? But you answered that question, but you did say you're giving them out in your study. What kind are you giving out?
Yeah, we, whatever you want. So I think, the best safe storage is the one that they're gonna use every time. So I think, I will say, we see a lot of, clinical settings offering cable locks because they're really cost effective, right? You can get them for about $5-10 a piece. When you're buying in bulk, you can get them for cheaper than that. But a lot of gun owners, that takes more time, right? So if you own a gun for personal protection, that cable lock may just be too long, to kind of really fit with your values on why you have a certain gun stored in a certain way. So one thing that we're able to do, thanks to having federal funding and being able to provide kind of these more tailored resources, we're offering biometric locks. So those quick access, kind of fingerprint, or quick access key coded safes as part of our study. Those are really popular, right? Because if you own a gun for personal protection, and it's really important for you to have quick access to a gun, then that oftentimes is going to be the preferred method. But I make no assumptions, right? Like, you may own a gun for personal protection, but that cable lock may actually be better for you. And so whatever you're going to use and use every time is the right device for you. So I think having a range of options to offer is always a great way to go if you have the financial resources to be able to do that. I will say, the Maryland handgun roster does certify different gun safes and locks. So you may have a local, law enforcement or other agency that certifies locks in your state. Otherwise, the Maryland handgun roster is a good resource to go to for like what's a really good quality device. Similarly, the California DOJ website certifies lots of them. So there are zillions of things to choose from, but you can find lots of ones that meet certain metrics for safety. Unfortunately, the Amazon Basics one isn't on there. Yes, yeah, in the back.
In terms of incentives for people to undergo training, I'm just wondering, there's, by the way, I'm Maureen Tierney, I'm the chair of public health. So thank you so much for this and for the panel last evening, and such a crucially important topic. And I actually lived in Maryland before here, and then Massachusetts before that, different states in their perspective. And my son became a hunter, which still like shocks the living daylights out of me. And we have our safe, where it's clearly protected safely. But, I know that one of the places he will listen to is the range, is the people who did. And so, partnering, I'm just wondering, as an incentive, if a range said, we'll give you an hour of training or an hour of time, if you go through this training, whether that might be an incentive, and whether you already done that.
Yeah, that's a great question. I can't speak a lot to broader initiatives about, kind of ranges trying to incentivize participation in safety training, but I will say that they're really important allies in this work. You ask anyone who works at a gun shop or range, and they could tell you someone they're worried about. And so a lot of, actually, I recently participated in in a panel in DC with other, federally funded firearm researchers, one of whom is leading the Gun Shop Project, that works with, gun shops and ranges, federal firearms licensees and ranges to provide lethal means safety counseling, right? How to identify, how to counsel, how to, broach these conversations and share information with gun owners from someone who is, closer to them, and also might be a more credible messenger to a gun owner about the need for safe storage, or when they might want to think about getting guns out of their house, or if they have a concern. So there's a lot of really important work in that area, and they are really important partners in this work. And there's a lot of great work that is being done in that space. Thank you.
Thank you.
Other questions?
I just have to acknowledge in the chat, several positive affirmations. This was phenomenal. Thank you so much for your presentation.
Thank you guys for the opportunity. Really appreciate being able to be here, especially to meet with a lot of members of the team, especially the community members of the team. There's just been a really great experience, and I hope to be back. So
We'd love to bring you back when our initiative gets further along. To that earlier question about gun lock boxes and trigger locks and what's the best tools to use. It's the ones that folks will actually use. CHI Healthy Communities did secure funding over the next 3 years to pilot the distribution of gun safety devices in CHI Health clinics that volunteer to participate in the pilot. This is part of an ongoing training and education series to increase awareness and create a more receptive environment for clinician firearm safety screening in primary care and distribution of resources.
Do you do it at the ER? Because we're a trauma center, right?
Yeah, so we do have a hospital-based violence intervention in the works as well. We're working with the Health Alliance for Violence Intervention, but let's have that conversation. In Lincoln Lancaster Health Department reached out to us and said, we have lock boxes and lockable pill vials, and we are distributing those in the emergency department at St. Elizabeth. So
I'm with the research office. I work with Dr. Tierney, so I wouldn't be the person to talk to, but
Yeah.
I would suggest that.
yeah, thank you for that suggestion.